Hello, Study Nurse IQ family. Welcome back to the channel. I'm Ginny, and today we are covering one of the most critical and highest yield topics for the NCLEX and for your clinical rotations, the 4 stages of shock. If you understand the progression of shock, you'll be able to anticipate orders, prioritize care, and ace your exams. This is truly laying the foundation for all your critical care nursing. Please stick with me to the end, as we have NCLEX-style questions to test your knowledge on the material. What is shock, the foundation? Before we get to the stages, let's define the core problem. Shock is not just low blood pressure. It is a critical syndrome that results in decreased tissue perfusion, meaning your cells, tissues, and major organs aren't getting the oxygen and nutrients they need to survive. Think of your body as a city. If the main power plant, your heart, is failing, or the pipes, your blood vessels, are leaking, the power goes out everywhere. When the cells don't get power, oxygen, they start to die. If we don't fix it fast, this leads to MODS, MODS, multiple organ dysfunction syndrome, and eventually death. That's why aggressive treatment is essential. The major types of shock, the causes. Regardless of the cause, they all lead to the same result: poor perfusion. Hypovolemic shock, massive fluid loss. Think of hemorrhage, bleeding, or severe dehydration. The heart is fine, but there's not enough fluid to pump. Cardiogenic shock, the heart is too weak to pump. Think of a massive myocardial infarction, heart attack. Cardiac output drops because the pump itself is failing. Distributive shock, this is where the pipes are broken. There's plenty of fluid, but the vessels are too dilated, too wide. This includes septic shock, severe infection causing widespread dilation. Anaphylactic shock, severe allergic reaction causing massive vasodilation. Neurogenic shock, spinal cord injury causing a loss of SNS control and massive vasodilation. Obstructive shock, there is an impediment to blood flow, such as a large pulmonary embolism or cardiac tamponade. The 4 stages of shock, a progressive crisis. Every patient moves through these 4 stages unless the underlying cause is corrected. 1. The initial stage, the cellular switch. This is the stage where the signs and symptoms are very subtle. You might not even notice them right away, but on a cellular level, a crisis is unfolding. The big takeaway: the cell, starving for oxygen, switches from aerobic metabolism, metabolism with oxygen, to anaerobic metabolism, metabolism without oxygen. The poisonous waste, this backup energy production system, creates a toxic waste product called lactic acid. The lab clue: since the liver, which normally clears lactic acid, is also suffering from low perfusion, the lactic acid builds up in the blood. We can measure this. A serum lactate level greater than 4 millimoles per liter indicates severe lactic acidosis and is a critical warning sign. 2. The compensatory stage, the body's rescue attempt. This stage is the body's attempt to save itself. It is reversible. If we catch the patient here and intervene, they can make a full recovery. The body uses a complex team of neural, hormonal, and biochemical systems to fight the drop in perfusion. How the body compensates. The sympathetic nervous system, SNS. The body senses a drop in blood pressure via baroreceptors in the carotid arteries and aortic arch. This triggers a massive fight-or-flight response, releasing catecholamines like epinephrine and norepinephrine. Effect: this causes widespread vasoconstriction, narrowing the pipes, which increases the heart rate and the heart's contractility to increase blood pressure and cardiac output. Shunting blood: the SNS shunts blood away from non-vital organs, like the GI system, skin, and kidneys, to the 2 most vital organs, the heart and the brain. Clinical sign: this is why the patient's skin is typically cold and clammy. The blood has been shunted away. An important exception is early septic shock, where the skin may be warm and flushed due to massive vasodilation. The RAS system, the fluid savers. The kidneys sense low blood flow and activate the renin-angiotensin-aldosterone system. Renin is released, leading to the creation of angiotensin II, a powerful vasoconstrictor. Aldosterone is released, telling the kidneys to hold on to sodium and water. The pituitary gland releases ADH, antidiuretic hormone, telling the kidneys to hold on to pure water. Effect: all of this works to dramatically increase the body's fluid volume to boost blood pressure and perfusion. 3. The progressive stage, failing and falling. In this stage, the body can no longer keep up and the compensatory mechanisms start to fail. Signs and symptoms are now obvious and severe. Failure. We see a complete drop in cardiac output and the patient is severely hypotensive. The mean arterial pressure, MAP, drops below 60 millimeters of mercury. This means blood flow to the brain is compromised. Cellular death and damage. Cells are now dying from hypoxic injury. Crucially, the capillaries suffer increased permeability, the vessel walls break down. Effect. All the fluid the RAAS system worked so hard to save now leaks out of the blood vessels and into the interstitial space. The patient develops massive edema, and the loss of intravascular volume causes the blood pressure to drop even further. Organ shutdown. Lungs increase capillary permeability, floods the alveoli, leading to ARDS, acute respiratory distress syndrome. The patient becomes stiff, non-compliant, and requires mechanical ventilation. Kidneys. Prolonged low perfusion leads to acute tubular necrosis, ATN, and renal failure. You'll see low urine output, high BUN, and high creatinine. Heart. Ischemia leads to dysrhythmias and potential myocardial infarction. Blood. The clotting cascade goes haywire, leading to DIC, disseminated intravascular coagulation. Microclots form everywhere, depleting clotting factors, which then leads to catastrophic, uncontrollable bleeding. For the refractory stage, the final shutdown. The word refractory means unmanageable or unresponsive. Once the patient hits this stage, it is irreversible. All of the organ systems are so damaged from prolonged lack of oxygen and the cycle of cellular death that treatment is ineffective. The end result is MODS, followed by death. All right, Study Nurse IQ family. Time to see if you can apply these stages to an NCLEX question. Question 1. A nurse is reviewing a patient's lab work. Which finding is the earliest and most critical indicator that the patient has moved from the initial stage of shock into a worsening state? A. Hypotension with a systolic BP of 90 mg/Gb, cold and clammy skin. C. Serum lactate level greater than 4 millimoles per liter. D. Oliguria, urine output less than 30 meter elb/hour. The correct answer is C. Serum lactate level greater than 4 millimoles per liter. Rationale. The initial stage of shock is defined by the shift to anaerobic metabolism, which produces lactic acid. A high serum lactate level is the earliest and most reliable cellular sign of hypoperfusion and inadequate oxygenation, often presenting before the obvious clinical signs, A, B, and D, that are characteristic of the compensatory or progressive stages. Question 2. A patient in the compensatory stage of hypovolemic shock is experiencing tachycardia and peripheral vasoconstriction. The nurse understands this is primarily due to the release of A. Aldosterone, which promotes potassium excretion. B. ADH, which promotes diuresis. C. Epinephrine and norepinephrine via the sympathetic nervous system. D. Angiotensin 1s, which causes pulmonary edema. The correct answer is C. Epinephrine and norepinephrine via the sympathetic nervous system. Rationale. The body's immediate fight or flight response is the activation of the sympathetic nervous system. This releases catecholamines, epinephrine and norepinephrine, causing the heart to beat faster and the blood vessels to constrict, vasoconstriction, all in an attempt to maintain blood pressure and cardiac output. Question 3. A patient is in the progressive stage of shock. The nurse knows to monitor for which severe complication related to the clotting cascade and vessel damage. A. Acute tubular necrosis, ATN. B. Hyperglycemia and Cushing's triad. C. Disseminated intravascular coagulation. D. Metabolic alkalosis. The correct answer is C. Disseminated intravascular coagulation. Rationale. DIC is a devastating complication of the progressive stage. Widespread vessel damage and cell death cause microclots to form throughout the body, consuming platelets and clotting factors. This state of overclotting is quickly followed by massive, uncontrollable bleeding out of multiple sites. A TNA is also a complication of this stage, but DIC represents the most severe systemic breakdown of the clotting system. If this video was of value or added value to you, please head to our YouTube channel, Study Nurse IQ, and click subscribe. Keep up the excellent work, and I will see you in the next video.